Good afternoon. I hereby call this third meeting of the Kentucky Health and Human Services Delivery System Task Force to order. I would ask everyone to silence your cell phone if you have not done so already. We have a lot of important items to cover today, so we'll jump right into it. Secretary, if you would, please call the roll.
Senator Rocky Adams. Senator Funky Fromeyer.
Present.
Senator Mays Bledsoe. Representative Heverin. Representative Mosier.
Here.
Representative Neighbors.
Here.
Representative Stalker.
Present.
Co-Chair Meade.
Here.
And Co-Chair Meredith.
Present. We do have a quorum, so we're duly constituted to conduct business. With that, let's move on to the second agenda item. That's approval of the minutes, which you have previously received. Is there any comments or questions? If not, I entertain a motion to approve. Motion by Representative Mosier, seconded by Co-Chair Meade. All those in favor say aye.
Aye.
Any opposition? There being none, minutes passed. First item on our agenda for discussion is nursing home inspections. If Secretary Freelander, if you would, please make yourself available to us, and along with Anna Mather. Appreciate you both being here.
Thank you. Eric Friedlander, Secretary of the Cabinet for Health and Family Services, and I'll try to find the right presentation.
Adam Mather, Inspector General for the Cabinet for Health and Family Services.
Gentlemen, appreciate you both being here this morning or afternoon, excuse me. Very important subject and a very unfortunate one. I'm sure you folks don't relish being here, and we don't really enjoy having to have this conversation, but we got a very serious issue that kind of caught us by surprise. Since you know the content of our concerns, appreciate if you would please proceed.
Absolutely.
Certainly. First, thank you for having us today. Even though I know the conversation may be difficult, the conversation must be had, and I appreciate the opportunity to address this with you all.
Yeah, thank you. I echo those sentiments, and we'll go into the presentation, then I'll save some time for questions afterwards. So some of the causes for survey delays are certainly the annual surveys are a CMS oversight intervention for their recipients at facilities. And so during COVID-19, they suspended all certification and recertification surveys, as well as life safety code surveys. And that suspension didn't end until November of 2021.
Excuse me, Mr. Mather, if you would pull your microphone a bit closer to you. I'm having difficulty hearing. Could be because I'm 70. May not have nothing to do with you, but just indulge me.
Yep, absolutely. Happy to do that. And then obviously in that time, COVID caused significant issues, and so we found facilities that not only voluntarily closed during and post-COVID, but we had under my tenure, we've had 5 involuntary facility closures, or forced 3 involuntary and 2 forced voluntary closures. And so in that time, too, we have worked with CMS to address how we can recapture some of the delays. So some of the things that we worked on significantly were around our complaint surveys. That seems to be where we find the largest number of deficient practices, and really they are very specific to addressing the needs of those recipients. And so we concentrated many of our efforts on complaint surveys, which are different than a certification or recertification survey. Additionally, this will come as no surprise to you all, but the vast majority of our surveyors are required to be registered nurses, and registered nurses are not easy to come by in this environment. So we've heard that from every healthcare entity, and we are no different in that respect. And so we are currently working, and we'll get to solutions in some later slides on how to bring our outstanding surveys into compliance.
And you'll see, we'll have a presentation on our vacancy rates, on our hiring, on our personnel in the rest of the cabinet, and these are two divergent stories.
So, one of the things that we've done is we've looked at individuals that have left our employment and why they've left, specifically around the registered nurses, which is the bulk of the staff that we have for the survey process. And many of them retired after the pandemic or during the pandemic. Some took jobs outside of state government. I read somewhere during the pandemic that registered nurses could make as much as $300,000 as a traveling nurse. And so obviously that's a very tough thing to compete with. Additionally, there was a lack of wages for a significant period of time. The workload is extensive. It is challenging in that they are traveling all over the state. They are spending nights away from their families. They have to, as a requirement of CMS, have to do off-hour surveys, and so they spend early mornings or weekends in facilities doing surveys, as well as once we start a survey for a certification or recertification, you can't break that cycle. And so what that means is that the surveyor needs to be there every day until we exit that facility. And so for some of those involuntary closures, I think this is important. We had a tremendous amount of staff there, or even our forced voluntary, and they were there for sometimes 30, 45 to 60 days because they work not only once we've identified that we're closing the facility, which takes a long time. One of the facilities we were in from 2019 to 2023, we were in there 22 times, a total of 22 times for significant amounts of time. And so we are there not only once we decide to close the facility, but we're there through the transition until every resident leaves that facility to make sure there's a smooth transfer for those residents. And that is a significant amount of time for our surveyors to spend in facilities.
And again, when you look at the cabinet, and we'll be presenting this later to you all, we've had significant increases in hiring across departments, and we have with nurses. That has been our incredible challenge.
Yeah, and I think that this slide kind of shows it, but I think the next slide really will help articulate what it looks like. So we've had a 20% turnover since the beginning of this year. We've only been able to hire 6 nurses. We have had people that have not made it through probation, which is not consistent for our office typically. And then we have all of our OIG nurse regulators, which require a higher skill set. We have all those positions vacant currently.
And this is a dramatic slide.
So the orange line that you see is the number positions that we need, and then you'll see the blue number is the number of surveyors that we had on staff. And you can see there's just a dramatic shift from 2018 to today. Thank you. And so I also want to talk about some of the solutions going forward. So we've increased our current nurse surveyors' salaries. We've created a special interest rate entrance rate that should entice additional nurses. We've worked with the personnel cabinet to create a nurse career ladder. And so it's a nurse series from 1 to 4. So LPNs can now come in where before we didn't really have positions for them. They can now come in as a surveyor and through education and tenure can work their way up into a kind of a lead surveyor role. Additionally, we've contracted through a company called Metasource additional surveyors to come in on contract. These are nurses that we're training. They're recruiting and getting them for us, and then if they meet our requirements, we were able to hire them on at no additional cost. As well as we've hired a third-party vendor called CertiServe, and they are providing surveys for us as well. And then lastly, I think we have worked with a company called HMS through CMS, has contracted them to identify areas of opportunity for us, as well as we're working with them to train our surveyors. So in addition to that, we've internally worked on a plan to look at our higher historical deficient higher deficiency facilities that trying to bring them into the recertification process sooner than later.
A couple of additional points. We're seeing this across the country. I was in Boston last week at a conference presentation from Pennsylvania. Not as severe as this. I'll be straight up on that. But the challenge of hiring nurses within a state survey agency and within a state has been a tremendous challenge. As I look across our departments, where we need to hire nurses, those are the departments that have been challenging in terms of hiring. Commission for Children with Special Healthcare Needs, not as severe as this, but still pretty flat. And so these are the challenges that we've seen, and we continue to work on it. Many of the solutions we worked on for DCBS social workers, increasing salaries to midpoint, working with temporary agencies to get them on more quickly, as well as trying to work on workplace environment. Those are all things we are trying here. I'm hoping we are at the nadir. I'm hoping we are at the bottom, but I cannot swear to you all. It has been a tremendous challenge retaining and hiring nurses, and that's exactly where we are.
And I think one thing to share with you all as well is once we hire these nurses, the training program is approximately a year, so there's no quick fix for this. It's called SMQT, and that's the training that is required by CMS, and they have to be certified in that before they are able to be in a facility by themselves. And so, unfortunately, it's not like hiring a nurse in a hospital where there may be a 30-day orientation. This is 6 to 9 months of training, just in the information, and then they're required to go on 2 surveys during that time, but typically it lasts about a year before they're certified and able to actually start providing work boots on the ground to help out.
I know we do have numerous questions, and we could please allow me to start first. On your first slide, you mentioned that annual surveys were suspended during COVID, but certainly I understand that. But was that a CMS directive, or did that come from the executive branch, or who made that decision?
That was a CMS directive. We did do what's called a focused infection control survey during that time, and we did meet 100% compliance on that. And so we would go in on shorter stints and do a infection control sweep of the facility, and we were 100% compliant during that time.
Well, you mentioned almost a 20% turnover. Can you give me a historical perspective on that? Is that routine, or is this?
It's high. I mean, this is the slide that tells you what happened, right? I mean, it absolutely is. We saw after, you see some up and down, right? But it really is starting in 19. Then you look past COVID, and it just dives off the cliff. And the challenges of bringing nurses in, asking them to go into facilities, and really at that point, we just couldn't compete with the pay scale. When private entities were able to pivot more quickly.
And as a nurse myself, I've never seen a more challenging environment for the profession. We're just, unfortunately, nationally not educating enough nurses to provide the care that's needed in the country. We certainly see it here in the state of Kentucky, but it's not specific to our state. It's definitely a national issue.
Well, certainly COVID exacerbated the problem, but
Absolutely.
Looking at your graph, it looks a noticeable downturn since 2018.
Yeah.
What was happening pre-COVID?
I think our salary structures in all of state government. I mean, we saw across the cabinet, right? We saw declines in personnel almost starting in 2017, I think, and so that was a challenge just in general to state government employment. So those curves looked similar to some of our other departments. It wasn't until that beginning of 21 where it just took on a different character.
And I want to thank our surveyors because they do a phenomenal job They work tirelessly. I was at a visitation for one of their family members last night, and 3 of their coworkers were there. It was just a really nice feeling because there is a lot of camaraderie, and they work so closely and so hard together. And I think I'd be remiss if I didn't thank them for the hard work that they do. But they went into the fire, so to speak. They never had a reprieve. We reallocated them temporarily to help out with other areas, and then as soon as we were allowed to do the infection control surveys, they went right in. They were at risk for getting COVID, more at risk because we were sending them into facilities that we had known outbreaks in. And so I think there was a lot of burnout, to be honest with you, understandably so. And I think, we tried to work with them, and we offered additional ancillary services that we offer through the cabinet. But I think for a lot of people, not just surveyors that were nurses or healthcare professionals, I think, huge burnout curve.
Most certainly, and I think our Commonwealth is blessed with a lot of great state employees, but a lot of great healthcare workers as well. And it's disappointing me that we have not recognized, I think, sufficiently the role that healthcare providers played during the COVID crisis, particularly nurses, because they're the front line, they're the soldiers, and it's been challenging for them. I think we tried to address the salary situation with the previous budget. I'm very proud that we took that initiative, but I think we need to make sure we stay on top of this. I appreciate you also mentioning that you kind of expedited onboarding of people. We talked last year during this task force about almost having dual organizations with the personnel cabinet and doing something with the cabinet. So have we done anything to change that? Because one of the recommendations we have from that task force was for you folks to get together and find out how we can expedite this whole process. So are we making headway there? Are we doing anything substantially different that will be permanent in nature in terms of getting people in these vacant positions?
Yeah.
Yes. And so we'll have a more general discussion about the cabinet where you'll see we've had much more success. A couple of things. We actually have started to begin the hiring process through a temporary hiring group so that we can actually bring people on board while we go through the personnel process. We've worked with Department of Personnel to identify where we had our own barriers, because I have to say we had some, right? That's true. And then where where we could improve the communication between the personnel cabinet and CHFS. I think we've made improvements. I think we've learned some things. And like I said, I think you'll see, unfortunately, not in this area, but in other areas, it's dramatic. It's as dramatic as this, except going the other way.
Good. I look forward to the discussion. I think that's later on in the agenda. We'll do that. Last question I have for you. You mentioned the recertification and prioritizing those. How are you establishing that prioritization scale? How are we doing that?
So we're currently looking at the historical outlying facilities, whether they had poor survey outcomes previously, and then length of time out of compliance. And so we're going to prioritize them accordingly to that.
But we need to be clear, we're way behind. We're way behind. And so we've got a long way to go to catch up. And it's probably, there's no quick fix on this. It's going to take us, if we're lucky, a year to dig out of this.
And certainly I think I speak on behalf of the committee that you have our commitment to provide the resources we need to do this, because it's that important. It's the most vulnerable population. We talk about the annual survey situation, but also the complaint surveys that you have. I know there's a backlog on those as well. So are we trying to do those things in tandem, or are we trying to give prioritization to which?
We are trying to do them in tandem, so we will add them onto the survey process. Now it is a catch-22 because it extends the survey process significantly, where you would typically have a 3 to 5 day annual certification or recertification survey. We're now tacking on, in some cases, 70 complaints that all have to be addressed. And so that takes a significant amount of time, and then it takes away from our ability to survey other facilities. And, I came from that industry. Those people are near and dear to my heart. That is why I got into healthcare. My grandparents helped raise me, and so I take it very seriously. And so it is, we think about it all the time. We take it extremely seriously, and we're working continually to optimize how we can get out in these facilities and address the issues.
All right, thank you. We have several other members who have questions for you. Senator Funky Frohmeyer, yield to you.
Yes, thank you, Chairman. I've had some great input from two very large facility leaders in Northern Kentucky and felt like the news articles were so unfair. Really acknowledging that the office has done a great job sending surveyors in, even if not for the annual recertification. There's been quite a bit of visits and surveys and addressing these issues. So just because the annual wasn't done, there's still been a lot of oversight. And so that was shared with me by two separate facility operators, in fact, texting me currently. But one of the recognitions is that need for the experienced and well-trained. And I recognize that my sister will be upset. My 58-year-old sister might be that ideal person. And I'm wondering if that's kind of a group that we are targeting, is the 60 and 70-year-old, that they've got that wisdom, they've got that experience, and perhaps that's not the same degree of taxing work that they were experiencing in Rita's case in the ER for the last 23 years. That now this is the next level for her to pursue. And whether it's being fashioned that way and shared and publicized as, all right, now we're ready for you to take this next promotion. But get them out of the everyday to day. I don't know. I don't
Well,
know.
if you want to send me her resume, I would.
She's
I
going to
will
love
gladly
me for
take,
that.
whether she likes it or not, we'll gladly give her a call.
That's right. And she'll be able to find 67 others as well.
Yeah,
for you,
yeah.
but-
Yeah.
We have so again, one of the kind of future pieces, but also relative to this, we've hired a recruiter, a full-time recruiter for the cabinet, and they've been focusing on DCBS and the Office of Inspector General. Like, that is where we have them aimed. Are any hospital association folks in here? Okay, so like that is part of what we do, right? We talk to folks about, this is it's still very stressful, but it's not the ER, right? I'm hoping we're at the, like I say, I'm hoping we're at the bottom, but I can't guarantee that. We're working though. I promise you we're working.
Representative Mosier, your question, comment?
Yes, thank you, Mr. Chair, and thank you all for presenting this. I know that this is not an easy topic, and we've talked about this before. I've spoken with you, Mr. Mather, about personal care homes and those inspections. So I know that this is a hard area. It's hard to hire folks. It sounds like you're being creative in thinking about how to best address this. I mean, I like the fact that you're now allowing LPNs to be part of this practice or of surveying. But it seems like when you look at the duties that these individuals have you given any thought to potentially breaking out those duties into two separate workforces? Somebody who could be that proactive surveyor who does the annual survey, who doesn't necessarily need to be involved in the reactive piece of when things are found to be going wrong. I mean, are there some CMS rules about hiring or
there's some
training?
CMS requirements about the recertification and certification. Certification is like your initial when you start, and then it's longer than annual, but over a period of time you would get recertified on a particular cadence. So they require teams of individuals to be on site for those recertifications and certifications. And so we did at one point, I think there were certain staff members that weren't completely trained on the long-term care, but unfortunately that is the bulk of what we do. And so it really hamstrung the organization when it came to scheduling and doing things like that. And so, and also it created a very unfair environment. You had individuals that didn't have to spend the night out or travel and they got the same pay. And
Yeah, but that happens when you're working as a nurse in a
Sure.
hospital. You have, easier days and harder
right, but
days.
but they just didn't want to do the training to have that, and so they never had to do those. It wasn't like they would occasionally not have to do them. They were never allowed to be assigned to those.
But we are looking
Yeah.
at anything.
Anything,
When
yeah.
I was, I think I've talked in front of this committee before. I worked all over the cabinet. One of the places I worked probably the longest was the Inspector General's office, 9 years. I was writing regulations. I actually got certified to survey dietary. It's about all I could pass. I couldn't figure out those prescriptions. But when fully staffed, there are more options. And I think if we were even close to fully staffed, we could think about other options. Maybe it's a way to attract more people. I don't know, but we can certainly look at any possibility to try to get more people in.
Right. One more quick question. When you're looking at these team of this team of folks who are involved in the inspections and the recertifications, have you considered partnering with DPH at all and the health departments? I mean, they already send folks in for inspections in dietary, right? And oftentimes they're medically trained, if not nurses.
I think it'd just be getting them certified. I'd be happy to talk.
And we'd have to
yeah.
address it with CMS.
Yeah.
That's something. I'm happy to do that, though. I don't think that's a bad idea. I think
Yeah.
it certainly.
We'll see if it falls in the DPH transformation plan.
Yeah,
but
we'll do that. And certainly nutritionists, dietitians can survey. They actually can be leads.
They do, yeah. We
yeah.
do have some dietitians, but they're in high demand as well at hospitals and other areas.
Right.
And so,
Yeah.
but
All right. I'm just the idea person.
Yeah,
no, we
thank you.
appreciate it.
Yeah.
All right. Thanks.
Representative Stalker, question, comment?
Yes, question. Thank you, Mr. Chair. As far as something is a solution, I'm just curious. When I was looking at the vacancy rates explained, the insufficient salary benefits, under benefits, I was just wondering, is a solution option potentially for reimbursement of student loans, debt? So I know my mother was a nurse. I have several friends who are nurses. It's know people who are still paying on that degree, and they've been graduated for many years now. So I'm wondering if that is a solution that you guys have explored, as far as if folks take a position and stay on in one of these roles, that there could be a debt forgiveness.
Not debt forgiveness per se. I don't think, and Michelle Barnes will be up here and be able to answer this question better than I, but I think I know, which is dangerous. But we have really just revived the program where we'll pay for folks to go back to school. It has more impact on the social service side than it does on necessarily the health side. But if you can get in and under the regular rubric of a surveyor, as a matter of fact, I think
Yeah, we have a HHS.
you could then
survey.
get some assistance in paying for additional college to get you to the point where you could be an LPN or an RN.
Correct.
But that's, as Chairman Meredith said, that's one of kind of the newer things that we have brought back.
Thank you.
Representative Neighbors.
I'm wondering, can you tell me about how many surveyor vacancies exist today?
Yeah, I have it. It's and it's a rough figure because I think they're interviewing somebody today, so I think I don't want to speak out of turn, but I think from the nurse surveyors, it's 53 positions.
And about how many positions would you like to have filled?
Roughly 83.
One other question. So is there anything that we as legislators can do that can help you all out with this situation?
Well, you all have already with ideas, and we appreciate that. I'm sure that we'll have discussions moving forward. There are a couple of places where I think discussions can be fruitful. I think it is how we support folks Is there some possibility around debt forgiveness, and what would that look like? I think that gets complex, but I think it's certainly worthy of exploration. Then I think I think we have some discussion, and we have the Nursing Facility Association folks in the room with us. I think there's some discussion about what do we want to look like, right? Even beyond just the survey piece, it is, we started a PACE program, and I think that's really a great kind of start. So it is, what do our structures look like that we can better support? And it's not just from a survey perspective, but it's like, how would we want to live in old age?
Thank you.
And I'm getting closer every day.
Thank you.
I have a final question for you, and it's related to the complaint surveys that supposedly is taking 2 to 3 years in some instances to get those resolved. Is that a personnel problem, or is that a process problem, or is it a combination, or are we looking at any changes to specifically address that particular problem?
So I think some of it is it's a personnel problem in the fact that they have not been uploaded because we don't have the personnel to actually spend the time uploading their complaint survey. So that's some of it. And then some of it is duplicity in the complaints themselves, where we may get the same complaint 5 different times. And so we've addressed it and gone out and looked at it, but we haven't uploaded the other maybe 4 times. So it looks like we really haven't looked at it. So it's, I think, a combination of both, in all fairness.
But primarily personnel.
Yeah, I would.
Yeah, primarily personnel.
I would think that when you've got that type of backlog, it really multiplies the inefficiency of the whole process, and perhaps we can do a in-depth look at the process itself as to how it could be streamlined and different. But appreciate that. Any other questions, comments? If not, we'll move on to our agenda. Adam, appreciate you being here.
Thank you, as always.
Thank you. This is one of those things that I have worked in the Inspector General's office for years, and it hurts. No other way to say it.
Our next item is discussion of turnover rates, kind of a continuation of this discussion we just had, and vacancy rates within the cabinet. And Ms. Barnes, I see you've made your way to the table. If you would, just identify yourself for the record.
I'm Michelle Barnes. I'm the Executive Director of the Office of Human Resource Management for CHFS.
Thank you for joining us this afternoon. Please proceed.
Thank you for having me. The administration has taken several steps to combat recruitment, retention, and turnover, working to ensure better compensation.
Ms. Barnes, I'd ask you as well, if you could pull your microphone a little bit
Okay.
closer, because I'm having
Thank
a hard time hearing.
So we've had the establishment of internal recruitment rates, which that impacts new hires as well as current staff, and then we've had targeted increases for job classifications. Some examples would be DCBS social workers. Okay. We've had the creation of locality premiums. These have been targeted areas. Oldham County, for example, for our correctional series. That's Department of Behavioral Health, where we had shortages there. Jefferson County, there's a variety of jobs there. That was mainly DCBS. And then all 120 counties, and those classifications listed are OIG-related classifications. December of 21, we had pay increases for social workers and family support. And then we also implemented a special entrance rate on July 1 of 22 for the social worker classifications. And that is across the cabinet for those. Of course, July 1 to 22, we had the 8% salary increases, the salary schedule adjustments that have occurred in September of last year, and we've got the upcoming salary schedule increases for this year, and then July 1 increases for 6% for all employees.
Thank you, General Assembly, for that.
Absolutely. Absolutely. We talked a little bit about this when OIG was at the table about the interim hiring process to expedite hiring for social workers and family support. We've also started that within OIG. So what that means for us is that we're automatically posting positions continuously twice a month. That way we can get the positions out there without waiting for our HR paperwork, right, to speed up that process. That's one thing that we've done to expedite the process. We automatically do that for them. So with that, that allows us to get those registers posted quickly, as well as review those registers to start the interim hiring process, which is the temporary process. So we don't have to wait for the our traditional hiring process, we can get those folks in the door and start the training while we go through that. We've hired a recruiter, and the secretary spoke about this a little bit ago. We also did interviews this past week for a second recruiter, so we're growing that program. The main focus to start has been to attend colleges and career center and other job fairs. She's doing everything from local fairs. She's going to go out to several of those. I know she's got 10 recruitment events scheduled already. And she's at the fair all this week, the state fair, along with staff. We've got a lot of HR folks that are helping out with that. We're also trying to utilize the virtual options, such as Handshake, which is a college site for active college students and their folks who have graduated. LinkedIn Monster, those are just some examples. We provide support. She's working hand in hand with OIG and DCBS to identify those hard-to-fill positions, and that's what she's targeting when she's out at those fairs to try to help with those areas. And then she's tracking those folks. When she's getting names and phone numbers and information, she's reaching out to the departments and saying, hey, I spoke with Susie. You should see her come through. So she's trying to track those and reach out to those applicants to make sure that they do apply after she has those conversations. It's not something that we've had before, and we're seeing some good results with that.
And because I'm old, I worked with her mother in the Office of Inspector General.
So another area that we've worked on in HR is we've hired a classification and compensation specialist. And with this, it's to help us evaluate our job classifications to meet our agency needs. We recently were able to implement a new OIG series. We've implemented and made upgrades to our audiologists. We have issues there sometimes, or not all the time with in that area, as well as, sorry, I lost my train of thought, the other classifications we've done. Oh, the epidemiologist for public health. So having that compensation specialist who was a prior employee, the personnel cabinet, she truly understands the compensation, the classification, so she can work hand in hand with those departments and our partner with the personnel cabinet to make the needed changes. We've implemented the Employee Educational Assistance Program for the first time this fall. We've received a lot of interest, so that, as Secretary spoke to a while ago, that'll be good for our OIG folks, and it's I think we've had 20 people, which is not a large amount approved, but we've had a lot of interest and a lot of folks asking questions, so we're really expecting to see an increase in that next year. And I've received a lot of emails saying, thank you for doing this. I'm so excited about the opportunity to be able to go back to school. So we're hoping that will help us maintain. And of course, if we pay for their education, they're required to work for us for 6 months. So it allows us to be able to keep them on hand as well. We sent out a survey to all employees asking, what do you need from us? What can we do for you? And we had an overwhelming response for a leadership and management program. So we're implementing a leadership academy, and that's going to start in October. We had over 200 applications for employees that said, I need management training. So we continue to grow our staff. And then, of course, we're reviewing the hiring process to identify areas where hiring can be expedited. So what kind of results have we had? If you look at these numbers, I think they're huge. January 1 of 22, we had a total of 5,748 filled positions. As of August 1, 6,582, which is a huge jump. Now, we have 7,077 vacancies, so we're still roughly 500 positions vacant, but we've made a lot of progress across the cabinet, so we're very excited to see this.
We had 600-700 vacancies in DCBS, and we're down to like about 150 now. So there's some real dramatic improvements. I think, unfortunately, I can never remember which committee I was in front of or what I was hearing, but I think it was this one where the court-appointed special advocates came and talked a little about that they've actually seen in the field, and I didn't ask them to do it, I promise. But they can see the turnover going down at DCBS. They can see more workers in DCBS. Not that there aren't tremendous challenges, as you well know. That's I think the last time I was here, we were talking about some of the tremendous challenges there. But we are making progress, and I think you can see that across a lot of our departments. That's what I was saying. It's kind of a tale of two different tales. We're making some I think dramatic progress in most every area, but with one exception.
Our turnover reporting, this is looking at separations and retirements. CHFS utilizes 237 job classifications. So, I mean, obviously out of 7,000 potential positions, that's a very large number. So this first slide focuses on our family support and social workers. So you can see number of positions we've had for this year, the number of separations and retirements, and those turnover rates. And then our second slide focuses on the nursing positions, again for 23, and what our turnover rates have been in those classifications. And those classifications are, of course, across the cabinet, not just OIG. The nurse consultant inspectors nurse consultant inspectors is what we've utilized in the past in OIG, so their numbers would be encompassed in those calculations. So that's it. Any questions? Thank you all.
I commend you on the idea to hire a recruiter. Certainly makes sense, but is this one person? That's an awesome responsibility for a single
Get ready
person.
too. Yeah.
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 And obviously I'm speaking from ignorance here, but does the personnel cabinet have recruiters?
They have recently put out an RFP and have had a response for that, for recruiting companies to assist agencies. We're waiting for direction on how that will work for us. I was in a meeting last week with Secretary Bailey and other HR executives where they've introduced it to us, but I don't know what it's going to look like. And it's my understanding that it has different areas that you can say, I need help with advertisement or whatever the case may be, and agencies have the option to reach out to those companies and pay for those services and utilize that. So we're looking forward to that, to be able to assist us in the future.
Does your recruiter report directly to you?
She does, yes, sir.
Is there any involvement in the personnel cabinet with this person?
Only from the HR sense that she reaches out if she will work with our class and comp person. And when she goes out, if she has conversations with people and she's wondering if, this person's going to qualify, those kinds of things. But no, she reports directly to me on her daily task. And honestly, I've given her a task and she's just ran with it. She's having to grow and develop it. It's not something that we've had. It wasn't there when I arrived. So we're learning, I would say. Trying to figure out what works, and we've got some work to do, which is why we're looking for the second individual that would be more of an IT type individual versus Melanie is out and she's the face.
When you identify a candidate, do they have to go back through personnel, or can you proceed with the hiring of that person when you've identified?
They have to go through the hiring process. The applying and qualifying and the interview process and all of that. The only way that we can expedite that process is if we hire them as an interim, because that would apply to a full-time merit appointment.
Well, I don't understand that process fully, but it concerns me a little bit. There seems like there's some redundancy there still that we can make this maybe easier, I would think, but possibly not. I am intrigued by the recruiter position. As co-chair of government contract review, you see a lot of contracts for agency nurses, and that's a very, very expensive proposition. And it looks like we could shift those resources into recruiters from the personnel cabinet and find those folks to fill those positions, because that's not a good way to spend money, and we're being in competition with every other healthcare provider when we do that sort of thing. So that's an intriguing proposition, and I hope that the personnel cabinet's following your success with that particular model. It needs to be pursued.
It's been a good model. We've had some success with it.
Yes.
Senator Funky Fromeyer, you have a question?
Yes, Chairman. Thank you. There has been tremendous confusion as recently as Saturday at a family picnic about the requirements of employment for healthcare workers, and whether that healthcare worker is a federal employee, a state employee, or an employer for a hospital network. What are the current requirements for mandates of COVID vaccinations?
I don't think we have mandates within our system anymore, and I don't even think our facilities anymore.
It's interesting because the nurse daughter-in-law of mine said, "Oh yes, absolutely," and the daughter-in-law who's a recruiter for health services said, "Yes, absolutely." But you're saying there's not. So I'm wondering if there's a tremendous communication gap that perhaps people aren't considering maybe re-entering. Perhaps they exited when it was required, and maybe they'll consider re-entering. Or I do wonder, because in my own small family circle, 2 young professionals, both in the ages of in their 20s, are unclear.
Right. And I think it's different at different levels. Certainly some facilities do, and they could be in the private sector or not. I can't answer for the federal because I'm not sure. So I think it depends on the facility.
Are the surveyors that we were just talking about in the previous discussion, are the surveyors required to have a COVID vaccine?
I don't know the answer to that.
I don't know. It ended in June. Thank you. Okay. Right.
In June of 2023?
That's what I heard from our audience.
And
They usually don't steer
perceivably-
me wrong, so I feel pretty good about it.
Perceivably, I
repeat the
would
answer?
propose
'Cause I'm
Yeah.
not sure everybody,
Yeah.
a lot of different folks
there's a
making
tremendous
motions back there.
disconnect.
So
Right.
what's the answer to the question?
Yeah, tremendous disconnect.
So, but they could also sign notice saying they were
Right.
declining the vaccine for a myriad of
Oh, yeah.
reasons.
There are certainly the exemptions that can be signed for that as well. Yeah. So that's as clear an answer as I can give you. I can certainly go back and look for sure and give you a sure answer.
I would hope to acknowledge that that's a symptom of a much bigger problem,
Right.
of the lack of clarity on that.
I would appreciate if you would convey that to the full committee so that we're all on the same
Certainly.
page here. Appreciate that. Question? Representative Stalker, you have a question?
Yes, thank you, Chair. Going back to the employee educational assistance program. So this is an area where you guys are already starting to look at how can we, with people that we already have, and these, if I heard you correctly, this is for folks who might be LPNs to help pay for them to go back to school to get their RN. Is there anything that we can do to go upriver a little bit more? Because I'm also concerned about if all of our LPNs start moving, are we creating a new gap? So I'm just wondering if there's any conversations around getting people in to begin with and getting them on the track to become an LPN, right? So like just keep going upriver a little bit further so that we don't create a new problem. So that's the first question. And then the second question is how did you guys come up with the 6 months? So I'm curious about how much are we paying for people to go back? Is it 100%? And how did we come up with a formula that they only have to stay for 6 months?
I can answer that part. There's a regulation around educational assistance that specifically sets out the requirements, and it says that an employee must stay with us with the state government for 6 months. They can change agencies; they just have to remain an employee of state government, or we should collect the money that we paid. Depending on whether you're working on a bachelor's or a master's, it's 3 courses, potentially could be 2, depends on their educational course. And this is not just limited to LPNs. This is offered to all employees within CHFS. It just needs to relate to their position. So we could have somebody who's an admin who works in Office of Inspector General who wants to become an LPN. We would pay for that. We would be able to do that.
Thank you.
You're very welcome.
Are most of these positions within the merit system?
Yes.
Vast majority. We can get you that breakdown.
80%, 90%, 95%?
Gosh.
As far as FFTLs versus our interim, hold on, I've got some numbers for you. I can find them. The numbers that we provided today are full-time filled positions. Those are merit positions. We have approximately 500 FFTL positions, what are federally funded positions that are unclassified, that are also filled as well.
But you're also thinking about true non-merit. So let me get you that number, right? I consider FFTL, right? They're not in the merit system, but they're not I don't think they're what you're looking at in terms of non-merit, right? You're talking about cabinet secretaries and division directors, and let me get you that number. It's
80 or so.
yeah, I can see my list, but it's I would say 80 to
80-ish.
somewhere in that neighborhood, but I can get you the exact number.
Well, the reason for the question is the merit system itself kind of poses a bureaucracy in addition to what you have to face otherwise. Is that a hindrance to recruitment and the personnel?
I don't think so. Remember, I was a merit employer for a very, very long time, and some of those protections, particularly, around the times that we are in, are important for them, and were important. I think you can look at salary structure and benefit structure, and we've all had the conversations around retirement and all of those things, and what works and what doesn't. Certainly, there's been some discussion around childcare and what can we support that way. But those are the challenges I think every employer faces, and then it's what's the flexibility within a merit system for that hiring. We've tried to do the interim hires. We've tried to get folks in the door so that we can get them through the rest of the process. But I know that that's not necessarily the best solution that you were looking for, but that's probably my best answer.
Again, purpose of the question is if it creates obstacles, and maybe they're unnecessary obstacles because it's an old system, been around for years. Isn't that something that the personnel cabinet and you folks could have a discussion about? Is how can we maybe amend the merit system, change the merit system to make this a little bit more fluid and make it a little bit more attractive and efficient for recruiting people?
I feel like that the personnel cabinet has been looking at that. I think they're coming forward with some proposals, and certainly have looked at comp and class for a while now. So I you're right. It's an old system in many ways, but I think it is certainly worthy of discussion. I believe the Department of Personnel has been looking at how to do things differently. So
I would agree.
yeah.
Any other questions, comment regarding this subject? If not, appreciate you. We'll move on to our next topic,
Thank you.
which is payment rates for Medicaid contracts. I see Commissioner Lee coming to the table. She was hiding behind the post. Couldn't see her. I don't know if that was intentional or not, but I think not. I always appreciate you being here, Commissioner.
Thank you. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services. Glad to be here today to talk about Medicaid reimbursements.
I appreciate that. Part of the reason for you being brought to the table today is we've had lots of discussions, a lot of different committees about payment rates for providers, and it seems to be kind of all over the board. And we hear anecdotal experiences like we haven't had an increase in 10 years, others we haven't had one in 20 years, and sometimes it's been 5 years. And that's why I wanted you to come to this committee to talk about the process in itself. And is there a way that we can start looking at this more in a global perspective? Because what I struggle with is if we make an adjustment for one group, then what's that do to another group? And when you got limited resources, it's tough to make those decisions within those respective silos. So I want to understand the process just a little bit more.
It's a very complex system, but we'll try to give a big, broad overview today, and more than happy to come back and with any specific information after we present. Again, just a quick overview of the Medicaid program. We currently serve 1.6 million members. That was as of July the 31st. We have over 600,000 children in the Medicaid and CHIP programs. That is over half of the children in the state. We always say that's nothing to boast about because those children live at or below the federal poverty level. We have 614 expansion members. That's as of July 31st also. We have over 69,000 enrolled providers. That includes both in-state and out-of-state providers. And in state fiscal 23, our expenditures were $16.8 billion. That includes both medical and administrative expenses. And when we talk about reimbursement, I think it's really important to talk about the directed payments, because when we talk about reimbursement methodology, we have some providers who have directed payments. Directed payments are in addition to the fee schedule. So I'm sure that you all know about the Hospital Reimbursement Improvement Program. You're very instrumental in getting that bill passed so that hospitals can receive up to the average commercial rate. We do have to have some quality measures tied to those directed payments. We also have directed payments for ambulance. We have a university directed payment, which is for in the teaching hospitals. So total expenditures you can see in directed payments totaled $8.5 million to those specific provider types there. Billion, I'm sorry. $8.5 billion dollars for those providers. We also have a directed payment for some durable medical equipment codes. And basically what a directed payment is, we have a fee schedule. We contract with managed care organizations. Managed care organizations can contract with providers for specific rates. Sometimes the managed care organizations will follow our fee schedule. Sometimes they may pay more or less. And what a directed payment does is allows us to give those providers more money through a directed payment. That means the managed care organizations, we give that money to the managed care organizations and direct them to pay a certain fee. We have to have approval from CMS to do this, and typically we have to have this approved every year. We have specific quality measures that are tied to those directed payments that providers must meet in order to receive those payments.
GME is out. Graduate medical education is a little bit outside of this, and so I know we have had some discussions, Representative Moser, about what that might look like, and you'll be happy to know we're talking with some proposals with both universities now.
Are those payments, are they factored into the MLR?
The directed payments?
Yes.
No, those payments go to providers, so
But you're going through the MCO.
we
to
go
the
through the
provider.
MCO.
So do they view that as part of the MLR? Or?
The payments that they give to the directed payments, I believe they are included in the MLR. They're included in the 90% MLR, but I will have to double check that. But I
Well,
believe
with
they are
that-
because they're payments to providers.
Are they getting 10% for doing nothing other than passing the payments through?
I have lovely arguments with the MCOs all the time about we have taken risk off of them with these directed payments. And then they talk about how that this has impacted, particularly on the Senate Bill 50, the PBM side, because they say they're paying more for pharmacy and they're seeing some of their pharmacy trends going up. So it's a lovely back and forth with them. I think the first year it was the way the directed payments were done is that it was included in the MLR, and I think we've made some changes since then, but I won't swear to it, and we can get back to you on it.
We'll double check how that pass-through is
I
calculated.
would appreciate that, because that's, I understand where they would come from, but I don't think that they have really done anything to generate that additional revenue stream. And most of these directed payments are a result of legislation that we have passed. So we've rewarded them for legislation that we've passed, even though they're doing nothing. We're trying to enhance payments to providers, which we're doing, but they're not getting the full amount of the payment. So it's we need to have additional discussion about that. Thank you.
And so we have a variety of fee schedules in the Medicaid program. We have listed those fee schedules, the update occurrence, comparison to Medicaid, and the regulation here. Typically, Medicaid develops fee schedules based on three methodologies: either a percentage of Medicare, based on some comparison to other states, for example, if there is not a Medicare fee schedule. And there's also a methodology called relative value-based system that's takes into account the relative value of services that are the amount of time and effort that goes into a specific code. And as you can see, we have the update occurrence on here, and I would like to point out that when you see that it's updated annually on 1/1, for example, we do update those procedure codes. We add new codes. We do not necessarily increase the rates. Behavioral health services, I would like to point out two behavioral health services and the dental fee schedule. We used to have two fee schedules. For the dental fee schedule, we had an adult fee schedule and we had a child fee schedule. The child fee schedule was higher than the adults. We increased those rates many years ago to see if we could get more providers into the program. We didn't see a huge uptick when we increased those rates for children. Recently, when we amended the adult dental fee schedule and enhanced some of the procedure codes, we moved all of those procedure codes to the child fee schedule rate. So there was a slight increase for some specific codes in the dental program. Likewise, in the behavioral health program, we had two fee schedules. We had one for inpatient and we had one for outpatient. And we combined those fee schedules, and which resulted in a rate increase for some. It was either inpatient or outpatient. We just took the highest code on each one, the highest rate, and made that the new code going forward for both inpatient and outpatient. So one fee schedule now. Also, the rural health clinics and federally qualified healthcare centers have a different payment methodology. They are paid on a prospective payment system rate. They receive 100% of the cost for doing their business. They do receive an increase every year based on a Medicare economic index. Our hospitals, we talked about, community mental health centers. Some of those are cost-based providers. Such as the community mental health centers. Our certified community behavioral health centers also cost-based. We only have, I think, 4 of those right now. That is through a demonstration grant where the certified community behavioral health centers will be paid on that prospective payment system rate, very similar to the FQHCs, the federally qualified healthcare centers, and rural healthcare centers.
Psychiatric residential treatment facilities, those are rates that haven't been increased in a while, and that's if I was going to point to one that needs it like now, those would be, because it helps kind of the back door out of our acute psychiatric hospitals for kids. So this is the way to maybe hopefully clear up some more space for them.
So as we talk about provider tax, we have some providers. For example, the Hospital Reimbursement Improvement Program is funded through a provider tax with the hospitals. There are certain provider types that can pay a tax. For example, dental providers could pay a tax and receive increased reimbursement, because I think the secretary has said in several meetings, we don't care what we pay you as long as we can get the state match. If we can get those funds from the state match, we'll be more than happy to increase rates. And the hospitals definitely took us up on that, and they pay a tax to get those enhanced payments. And they can be up to 5% of revenue. It has to be a flat tax across the board, for example, and it has to be applicable to every single provider in that class. So every single hospital has to pay that tax. Likewise, if we imposed a tax on the dental community, all dentists, regardless of whether they took Medicaid or not, would have to pay that tax. Some states do use those taxes to accomplish several things, and that, of course, is an increase in payment rates, which is the most common, and to fund some supplemental or directed payments, such as we do with the hospitals.
And I think I've testified here before that as we talk to providers, and what I've said to them all is, you can't depend on us to continue to just add more general fund and add more general fund and add more general fund, particularly as it relates to payment rates. And that if we could work some of these kinds of things out where they come up with and for lack of a better term, quarter on the dollar, quarter on the 75 cents, that those would be ways that we could work together for that. And we have some good examples that we started with. and the challenge is it's a broad-based tax. And so even those folks who may not accept Medicaid would have to pay that tax. And that was many years ago when those broad-based taxes were in place. A lot of folks were like, I don't take Medicaid, why am I getting taxed? And that was the real challenge of implementing that on a broad basis. So I just want to kind of give that background.
Are those measures specific to the hospital, both inpatient and outpatient?
Yes.
Are those viewed as directed payments?
Yes. So that you have a limit on the amount. I'm going to get into the weeds, and Steve Bechtel, who is our Medicaid budget guru, will probably not be happy with me explaining it this way. But basically, the hospitals, it's the difference between what they're getting a Medicaid rate and then that average commercial rate. That's what we've done. So between that Medicaid rate, the average commercial rate, they're paying the state share of that difference. So that then produces the funding to do the directed payment. So there are no state general funds involved in that increased payment for hospitals. And because then we have been able to increase that actually increases the headroom on the provider tax for the hospitals. That's kind of how we were then able to spread that out to outpatient. And I think what we're going to see, and I hope this is good news, is a majority of that outpatient is going to go to rural providers, as opposed to the majority of the inpatient went to more of the urban providers because it's based on the number of inpatient beds. We're still looking at that. We'll get you a report when we know, but I think it's going to be I anticipate it being a very successful program, particularly from the perspective of keeping rural hospitals open.
I like it when you sweet talk me. But I am still concerned about the MLR.
Mm-hmm.
That's something I think we need to take a very hard look at, because every time we do one of these measures, we're giving the MCOs an increase that I don't know that's deserved. Maybe a portion of it as administration for the program itself, but I don't think it gets the full measure of the funds to the providers that we intended for them to get. Mm-hmm. So again, I think we need to have some conversation.
And I think we're taking risk off it.
Mm-hmm. Yeah. Mm-hmm.
We just listed some legislation, both state and federal, regarding the provider tax in case there was interest in further analysis of that legislation. Again, federal requirements has to be broad-based, uniformly imposed, and it does not hold the taxpayers harmless. Again, just more federal requirements. We list those provider types that are eligible to pay a provider tax: physicians, home health care agencies, outpatient prescription drugs, services performed by managed care organizations. Again, listing of those provider types that can pay a tax and receive some directed payments or pay that state match.
Have you had any groups that come to you to request the same type of relationship that those who are paying the tax have for matching funds?
It's actually the other way. I've gone to those groups, and say, please talk to the hospital association. I think their experience is good. I think your experience would be good, but we just haven't had any takers. The only real other taker that we've had are the ambulance providers, and that's really been about it on that uptake. I take that back. Some of the waiver providers also have a provider tax, but it's just for a certain part of the waiver providers, not all of them. And I can't remember which one. Is it SCL? Oh, look, I guessed right.
SCL.
Yeah.
And speaking of SCL, that's one of our waiver programs, the supports for community living. You know, that CMS states that we have to have an approved or a sound rate methodology program. We are in the midst of the rate survey. We hope to have that completed for the waiver program soon. Waiver providers did receive some increased funding both through Appendix K and through the budget bill during the COVID public health emergency. And so based on the provisions from CMS, we have to continue that rate increase going forward. We used the ARPA funds to increase the rates for our waiver providers. So going forward, we will need to find a way to continue those increased payments to the providers.
And before we get to questions, Lisa and I were at the same conference last week, and your initial question around, you're right. Basically, the person that gets the rate increased is the one that, it's a squeaky wheel, right? And I don't mean that disrespectfully, but it is. And there are some states now that we talk to, a few that are looking at how to do what you're asking. How do we do this on a comprehensive and regular basis so that we don't have one here and one here and one here, which is what we've done here. And I think there's some examples from other states. Was it Iowa? Am I going to call it right? Where they've taken a more global approach. And I think there may be some examples for this committee on how we might go about doing that. It was news to me, frankly, at this conference. So I'm interested to pursue some of that and see what other states are doing. There are a variety of them. Some are more based looking at cost containment. Some are more based on looking at equal provider and regular increases to keep the healthcare environment healthy. So it's it's different depending on which state you're in. Most of the northeastern states are cost containment based. I think more of I would say it's kind of central states like the Iowas and the Dakotas. They have their approach is slightly different about what is that, how do we do this kind of umbrella where we get all the providers at once and not just one by each. We'll be happy to research the examples. I know you'll want us to, and we will certainly provide them.
And we have been working with our technical advisory committees. For example, we have almost 22 technical advisory committees ranging from hospitals, dental providers, a range of advisory committees, behavioral health. And sometimes it's not that big, broad increase across all procedure codes. We have asked some of our technical advisory committees to, if there are certain codes, if there's just a handful of codes that you could increase and that would have an impact on the population that we serve, what would those increases be? We have received a specific set of codes from our behavioral health community, for example, that we're looking at right now, to see if there's anything that we can do to make a huge impact on the population we serve and to increase some of those rates for the providers that they see as very vital.
One of the last two sessions, we've had a lot of discussion about dental rates, and that's kind of ongoing, and that's folks who I'm still hearing from. And, particularly in rural communities, it's difficult to offer that benefit if you don't have anybody to provide the service. And that's what's kind of generated this topic today is how do we make that decision within this vacuum that we have without understanding the impact it has on everybody else. So if other states are doing it in a more comprehensive, holistic view, I would be interested in that. And I think we can do a better job. Would save you folks some time, save us some time. I would hope at least there would be some justification for what we're doing,
right,
rather than have to pick winners and losers.
Mm-hmm.
Any questions? Representative Heverin.
Thank you, Chairman. I have a question for the table, of course. Good to see you all. Can you give us the status of the PRTF rate number 2 as you all know, that's something near and dear to my heart. We'll be having more conversations about it Thursday at the state fair, whenever we bring in some of the different organizations that receive those rates. But can you give us a status on the second tier?
Sure. Right now, we are looking at increasing rates. That the rates haven't been increased in decades. It's been a while, and so that has really impacted the development of that level of care. I'm not sure we even have any PRTF2s at this point. I don't think we do. So there's a lot of work to be done there.
Can I have a follow-up, please? I would like to see a timeline for that. Of when
Certainly.
you all expect to have that, a rate for that, and what that looks like.
Very soon.
As
We
a
actually
follow-up.
we've been talking with CMS about and putting a filing in that we want to increase the rates.
Okay.
So
Thank you.
we're right there.
Thank you.
Mm-hmm.
Any other questions? Representative Mosier.
Thank you, Mr. Chairman, and thank you again for this pretty comprehensive report. We always have lots of questions, and I love the idea of putting together a global coalition of some sort to really take a look at rebasing. I mean, I think we need a systematic update as to how to handle this. So just know that we are looking at that, and happy to work with you on that. When somebody is facing a rate increase or decrease, is there a way for them to have input about that? How does that happen? How do providers submit feedback?
Typically, if there is a rate change, providers should receive notification prior to. We have been looking, when we look at our rates, for example, we don't want to decrease any. We would like to increase, but if there is some sort of an increase or decrease, they should receive notification, and we do have the technical advisory committees that they can come to and bring their concerns. They can also reach out to the department. But typically they should receive a notice, and then we can have some conversation.
And an example, though, when this was unintended, we had we have some of our rates are pegged to Medicare, and so Medicare took some rates up and some down, and we got surprised with the behavioral health rate that went down a little bit, and we didn't catch it. We fixed it once we found out, but that was provider feedback that got us there. So when they sent us that message back that, hey, you cut a rate, and we didn't, I mean, I hate to say it, we got a lot of rates, and we just didn't realize that was the impact of the Medicare reduction, so we restored it back to what it was. But that's really, really rare when that happens. I hope that that's the only time it ever happens, but it did happen once quite recently.
Okay, thank you.
Any other questions, comments? I have one final one for you. The fee schedules that you developed that are passed on to the MCOs, are they contractually obligated to pay that amount?
No.
How much variability do they have in that?
Well, they have the ability to negotiate rates. And so it is what a provider or group of providers will accept. Sometimes occasionally they have to pay more, but you and I both know a lot of times it is not that. We've encouraged them to get into some of the value-based contracts pieces, because that's a different pay model, hopefully, that you're paying for quality, right, as opposed to volume. We've got a long way to go. That's actually what I would suggest if I am not here, and what I would suggest if I am here, is I think that because of what we're doing with directed payments, where there's a quality measure piece of it, because of the quality measures that we have in the MCOs, because of the quality measures that the the federally qualified health centers, have to meet, I think it would be really good for us to really talk about what does quality look like? What are those indicators that we want to work on together to actually improve the health of Kentuckians? You talk about it all the time. So we don't have alignment across those measures. And I think it would make sense for us to have that discussion. What is it that we want to see improved, and focus our efforts there? Not, I put this up to my firm grasp of the obvious, but I don't see a lot of states going in that direction, and I think it's something that we could do together that could make a real difference.
How many of the services do we provide that have a value-based contract?
Not a lot. I know a few. There's some providers that have entered into that and have actually aggressively tried to enter into that with the MCOs. I think an example of that is probably VOA. That's probably my best example. There are a few others than that, but Jennifer Hancock and her group have done a really, really good job on that. So that's the best example that I can come up with off the top of my head.
Well, that's a good example. I've talked to those folks who really like the work that they've done. I think there's real value. And what impressed me most about it is they kind of developed the quality criteria. And that's what I would suggest, that this direction we're going to go with healthcare providers, is have them tell us what's quality. Because I think all reputable healthcare providers want to do a good job, and they a little bit resent those who do not do a good job and skirt the issue. So that's something we continue to explore. Any other questions or comments about this particular topic? If not, we'll move on to our last topic for today, which is update on waiver programs. And Commissioner Lee, thank you. Always appreciate your presentations.
Now I can't get this down.
It's not a touch screen.
Ah, dang it. There's the mouse. Thank you, Lisa. I was doing so good.
Ms. Stade, if you would, come to the desk.
Is yours on here, or do you have one?
I think so. I think it's on here. Oh, yeah, it's this one.
Okay, got it.
Thank you.
I take my role as Vanna seriously. There you go.
Thank you so much.
I'm not sure who that old guy is with you, but if you would, please identify yourself for the record and feel free to proceed.
This old guy is Steve Shannon.
Yeah, I know you.
I'm the executive of CARP Association 1214 Mental Health Centers, and I dabble in waivers.
My name is Amy Stade, and I'm the CEO of the Kentucky Association of Private Providers. Are you ready?
Yes, ma'am.
Okay.
Please proceed.
Good afternoon, and thank you to the task force for asking me to be here today. Again, I'm Amy Stade. I'm the CEO of the Kentucky Association of Private Providers. We are the statewide trade association representing providers who support individuals with intellectual and developmental disabilities through special Medicaid programs called 1915C waivers. Steve already introduced himself. But just as a baseline, for those that don't know, Kentucky has 6 1915C waivers, 2 brain injury waivers, the acquired brain injury waiver, and then the acquired brain injury long-term care waiver, the home and community-based waiver, which typically serves our 65-plus population, but also serves individuals with significant health needs, the Model 2 waiver, which is for our vent-dependent population, the Michelle P. waiver for individuals with intellectual and developmental disabilities. That waiver has a cost cap and an hour cap. So generally speaking, individuals can only receive about 40 hours of services per week through that waiver. And then the Supports for Community Living waiver, which is also for individuals with intellectual and developmental disabilities, but is really a 24/7 care waiver. And importantly, includes a residential component, which the Michelle P. waiver does not. So again, CAP members generally provide services through the SCL and Michelle P. waivers, but our members are involved in the ABI waivers and also do support individuals through the home and community-based waiver. So over 30,000 Kentuckians are supported by all of our 1915C waivers. That's about 1.9% of the total Medicaid population. So we are talking about a small population. These waivers allow individuals with significant disabilities, brain injuries, or the elderly to continue to stay in their communities and prevent unnecessary institutionalizations. Like I said, some of the waivers include 24-hour care and residential services. So just a quick overview of some things I'm going to go over today. I'm going to give you an update on two different task forces, 2020 and 2021 task forces related to these services, waiver wait lists, funding, and then some recommendations. Please know that this is not an extensive list of what's going on with our waivers. This is a fragile system that hasn't really recovered from the pandemic. Workforce is a constant issue. It's affecting providers' abilities to support people with disabilities and to keep them in their communities. And it's really having an impact on residential services, which is the backbone of our SCL waiver. We're seeing providers actively get out of the residential business faster than we can add them back, particularly with one model called the staffed residence model. We are incredibly grateful for the support of the General Assembly. You all included funding in the last budget. Without your support, I'm really not sure where we'd be today. It was incredibly important for our providers. The funding we received literally saved our services. And there's still some work to be done to reduce red tape and kind of reimagine services to ensure the long-term survival of our waivers, but we're on the right path. So, like I said, we've had two interim task forces, 2020 and 2021. So recognizing the importance of our 1915C waiver services, the General Assembly established these two task forces to make findings and make recommendations. Most recently was the 1915C Home and Community-Based Task Force, which you, Senator Meredith, were a part of. And during that, they it was a bipartisan legislative task force. They made 6 important findings and 15 recommendations. The task force found a number of things: that providing these services in community-based settings was the most cost-effective way to provide this care. More than 10,000 eligible Kentuckians were waiting for waiver services. That there was a well-documented direct support professional workforce crisis. Part of that was caused by low funding for wages. And there's some other policy recommendations. So in response to these findings and recommendations, the General Assembly did grant these services a rate increase in the last budget. So that was a phased-in 20% rate increase, while also preserving a 50% rate increase for certain residential services that had existed since the beginning of the pandemic. That was just to ensure that those providers didn't receive a rate cut. I'm not going to go through all the recommendations. They're in your packets, but some of the recommendations were to enact legislation to establish residential crisis services, enact legislation to establish a waiver service for participants with exceptional support needs, direct the Cabinet for Health and Family Services to ensure continued access to cognitive rehabilitative services through our ABI waiver, which has recently become a really big issue as some of those OT, PT, and speech services have had to move to the state plan due to some recent federal guidance. Direct the Cabinet for Health and Family Services to develop a plan for transitional services, and direct the Cabinet for Health and Family Services to coordinate with stakeholders to implement regular cost of living adjustments, wage analysis, etc. Again, the full recommendations are in your packet, but I did want to make you aware that we have the roadmap. We have lots of recommendations from this General Assembly, and we would love to work with you all to implement those recommendations. Wait lists. I know everyone has a lot of concern about the wait list numbers, as do we. These are current as of July 7th, so some of these things have changed. So, for example, the home and community-based waiver no longer has a wait list. On August 1st, that waiver renewed, so all 1,094 of those members will be receiving notification that slots are available. That process takes some time. I wouldn't be able to tell you if all 1,000 have gotten that notification yet, but they're working through that list. But generally speaking, there are about 11,000 people waiting for services. And Steve is going to talk a little bit about this in a minute specifically, but eliminating the wait list is not solely about funding. That is a big part of it, but there are some administrative things that we could do to help move this along. First would be to standardize waitlist management policies across all of the waivers. They have different waitlist management policies, and we feel like it's important to standardize those. To create and implement an emergency criteria for all the waivers. So right now, the Supports for Community Living waiver has an emergency criteria. So if an individual with a disability suddenly loses their parents and they need some place to live, they can apply for an emergency slot, which the cabinet holds some slots back to use for this emergency purpose, that allows them to immediately access a slot if they meet the criteria. The SCL waiver is the only waiver that has this emergency criteria. The Michelle P. waiver does not, and we would love to see an emergency criteria for all of the waivers. And then again, we would like to see the state seek federal approval for immediate reallocation of a waiver slot when a person dies or voluntarily and permanently relinquishes their waiver slot. So right now, waivers operate on a plan year, and they all have different dates, but I'm just going to use January to January for simplicity. If an individual dies on January 2nd, their waiver slot cannot be reallocated to someone on the wait list until the next January 1st, even though that person is not going to come back and reaccess that slot. We are aware of at least 3 states which have policies in place that allow for reallocation of slots when someone passes away. So we do believe that it to be possible, but I think we understand that it is necessary to get federal approval to change some of our waitlist policies. Steve, I believe, is going to talk about the financial side of eliminating the waitlist.
Again, Steve Shannon with CARB. I've been working with a group out of Louisville. ARMS actually came to pass in 2003 or 4 when there was concerns with waiver rate cuts at that point. And they kind of got reinvigorated primarily over the HCB waiver that never had a waiting list and now did have a waiting list. So that group is looking at what's the next step. I took it upon myself, and I think the group decided, what does it look like to address the waiver? What's the cost associated? So really, I'm going to talk briefly, and my PowerPoint with more details is in your packet. If you want to meet one-on-one, I'd love to do that and go through that, but just give you an overview of the numbers based on some basic assumptions that were made. But this is what it looks like right now. The HCB waiver now is 0, so I would ignore that one, but it's going to grow. There's no reason to think it got to 1,000 relatively short period of time, a year or so. That's going to happen again. The Michelle P. at 50 placements per year, 2191, number 8,398 will get services. 168 years, the current 50 a year. SCL, 65 years, so the last person gets served. Scary stuff. You know, we had this interesting, there was an initiative in 2000 to do the waitlist stuff. Bill was introduced, and there's 2 members of the General Assembly who were co-sponsors. Representative Bratcher and Representative Palumbo were actually co-sponsors to look at the SCL waiting list in 2000, and they funded slots. So, thank you. What I've done is just prepared a model to eliminate the waiting list in 2 years, the next biennium. Hugely expensive, probably unrealistic. A 4-year model or a 6-year model. I can do an 8-year model, but the point is, one, we need to have some plan. I think the wait list needs to be addressed aggressively, and the wait list management needs to be strategic so we know what's going on, because names will be added. The numbers that you're looking at are based on July 7th numbers. Numbers have changed since then, and they will continue to change. Prior experience has taught us that if you fund a lot of slots, wait list actually increases because people now think I need to get on there because there's hope for me getting services. So those numbers will change. But looking at this, so what I've done is a model that is 2-year or 4-year, 6-year model based on next biennium, state fiscal year 25 and state fiscal year 26. Again, this is just flat numbers. I'm not adding the protected growth, but there will be more people added to it. And basic assumptions I've looked at is the first year you're not going to serve everybody who gets awarded a slot. It's just not realistic to think you're going to have in July, if you fund 1,000 people getting services. So the first year I phase it in over a 12-month period, and it's just divided by 12. So July you'll have 12 months of service. Some people won't get services till June. They'll have 1 month in that year. It lowers the overall cost for the first year. The second year of the biennium, you repeat that. Second year, you would have a full year of those people from 25, and then you phase in again. So that's the basic premise. So the first year, it's less expensive because you're phasing people in. Takes time to get people identified, time to get people eligible, time to identify a case manager, plan for services, all stuff that our agencies do now. You can't do a lot of people quickly, so you phase it in over time. That makes a different number. It lowers that number. Go ahead. And I use the existing match rate, so that may change as well, but that's the existing match rate. Go ahead. And that's just how it looks. If you get enrolled in July, you'll have 12 months worth of services. If your person enrolled in June for that fiscal year, will have 1 month worth of service. That lowers your cost. Go ahead. This is it. Down and dirty. My PowerPoint's in your packet has many more slides to go over what this looks like. But essentially, if you eliminate the waiting list the next biennium, again, that's 12,724 people with the HCB at 1,000. Again, that's a different number now, but that's what it was when we did this. It seems a big lift. That's 6,362 people a year. Fiscal year 25, a total cost of almost $220 million, $219 million. State General Fund, using the existing match rate, about $61 million. The second year, $623 million is what it would cost. And again, there's a big jump because that second year, all those people from 25 are getting a full year's worth of services. And the second cadre of people get phased in over time. So the first year, you phase it in. Second year, all those people get 12 months worth of service. I'm a first-year person. I get phased in. Year 2, I get the full year. Amy's a second-year person. She gets phased in the second year, not the full year in the biennium. So that approach, again, 2 years to eliminate, runs about $840 million. State General Fund is about $233 million. A huge lift. Is it realistic to almost double the size of our waiver capacities in 2 years? Perhaps not. Perhaps not. Amy agrees with me. The next model is 4 years. So you just divide it by 4. Right? So we're going to do half the waiting list in the next biennium, and we understand General Assemblies can't obligate future General Assemblies to spending, but the model would be, can we do this in 4 years? And you look at those numbers, you serve less people. And it's important to remember these are individuals we're talking about, just not people on a wait list. They are real live people. So you go down to about 3,200 people in the first year, your costs drop in half. Kind of intuitive. You're going from 2 to 4 years, costs will drop in half. $110 million to serve those people, about $31.5 million state general fund dollars. And then the next year it jumps to 311, and that's $86 million. So overall, that's going to cost you $116 million when you get the federal match, and that serves 6,362 people, half the waiting list. Next one is 6 years, $73 million. But again, you're serving 2,121 people. You're not serving 6,362. You're serving fewer people. And that may be a realistic plan. Still, that's going to cost neighborhood of $78 million. Now, I want to tell you candidly, cabinet staff will have a much more accurate number than I have, but I took the existing rates, the average cost per year, grossed it up by the 10 and 10 people got, so I think my average numbers are good, right? And just counted months for the first year. But I think that staff will be more accurate. Your staff will have probably a more precise number than mine. This is just, again, the ARMS group, this is what it looks like. Can we do this going forward? And in terms of state general fund, eliminate it in 2 years, $233 million. Is that feasible? I don't know, truthfully. I like to tell you there's sufficient capacity. I do believe as more people are served, more providers will expand because there's an opportunity to serve more people. When the SCL and Rochelle P. Waiver increases by 50 people, some select participant driven, they kind of manage their own program, hire on people. You don't know how much. You may only get 1 or 2 people. You're not going to gear up. Larger numbers, providers should gear up. Again, Amy agrees with that, should gear up to serve more people. But this is just an approach. And I think again, the wait list can become really burdensome. It gets really large. People continue to grow. I mean, people will be born who need services. And I think we just need to figure out a way to get to a place. And these are just models. The 8-year model, I did that quickly today that runs about $60 million state general fund. And that's serving a fourth of those people. So you're actually in the neighborhood of serving almost 1,600 people in the first year of the biennium and close to 32 in the second year. And that's $60 million across those waivers. Thanks.
And then the last thing we really want to talk about is the funding model for rates. And there are a lot of moving parts here. So bear with me, and I'm kind of going to do a level set with the next slide, because we've got a lot of different funding from a lot of different places happening currently. So again, just a quick level set. Appendix K afforded our 1915C waivers a tremendous amount of flexibility and was available during the public health emergency and is currently in the process of being phased out. It was enacted in the beginning of the public health emergency. It began becoming phased out when the public health emergency ended and will be completely phased out on November 11th of this year. Kentucky has used the Appendix K process to make significant changes to the way our waiver services are provided. And they also use the Appendix K process to implement the House Bill 1 rate increase. So the rate increase from the budget bill last budget, they used the Appendix K process to do that. They were directed by the federal government to use this process to implement that rate increase. But I'm going to come back to why this is important, but it's because it is really important. That's not the traditional way that states implement rate increases. Again, this was the federal guidance we got. We sort of do what they tell us to do, but it is going to become important in just a moment. Again, 2022 House Bill 1 rate increase. It was a phased-in 20% rate increase for all waivers, all services, and it made that 50% rate increase for certain residential services permanent. The 20% was phased in July 1 of 22. The initial 10% was effective July 1 of 23 effective. The federal approval on that ended up taking some time. And so while that rate was effective, providers couldn't actually bill that first 10% increase until of about March of this year. The cabinet did perform a mass adjustment and did a bunch of different things to make sure providers got that money dating back to July 1. But that federal approval did, unfortunately, take quite a bit of time. We used American Rescue Plan funds for that. There was a section of the American Rescue Plan Act, ARPA, that specifically addressed these home and community-based services and included an additional 10% federal match. These ARPA funds that you all used for this rate increase could only be used for HCBS services, for our waivers, that you couldn't take them and give them to, for example, a school system or something like that. There are very specific parameters about how they could be used, and they could only be used to expand, strengthen, or enhance Kentucky's home and community-based waiver services. So again, you all appropriated a portion of that to fund the first 2 years of the rate increase from the last budget. Again, the Cabinet for Health and Family Services has been in the process of, like Commissioner Lee said, in the process of establishing a verified rate methodology, which is required by the federal government. We have to have one. We've been undergoing this since about 2017. In the fall of 2022, the Cabinet for Health and Family Services completed the rate study and issued rate recommendations. They released those rates in draft form, posted them on their website, and did receive some feedback. At the time, it was estimated that the rate study would be fully implemented by fall 2023, but that has unfortunately not come to fruition. To finalize the rate study, just so everyone has an idea of what the steps are, the Cabinet for Health and Family Services must complete at a minimum the following steps. They would have to amend all of the waivers, submit each amended waiver for public comment, respond to the public comments, obviously seek legislative approval to increase the reimbursement rates as well, submit each amended waiver to CMS for approval of the proposed rates and the rate methodology, and then promulgate new administrative regulations reflecting those rate changes. So as I mentioned, the rate increase that was included in the budget is tied to the is tied to Appendix K, which expires on November 11th. There have been concerns expressed about what happens to that rate increase when November 11th comes around and Appendix K expires. So there has been this conversation that Appendix K could be extended for an additional 6 months after it expires. While that is true, the federal government kind of threw all states for a loop on August 2nd when it released a state Medicaid director's letter. That Medicaid director's letter outlined that several things about how states can ask to have their Appendix K extended and what items from their Appendix K they can extend. What that letter said is CMS will only approve these extensions for items in Appendix K which the state demonstrates that it will make permanent and will make permanently include in its waivers. The way the state does that is that before November 11th, 2023, the state of Kentucky must prepare and submit waiver amendments for each of our 6 1915C waivers outlining what changes it wishes to make permanent. Hopefully in that would be that 20%, the House Bill 1 rate increases that were granted by the legislature. And to be clear, if the state does not do this, on November 11th, that rate increase will expire and the rates will go back to what they were in 2019. Now, normally this wouldn't be concerning. If we were using the traditional Appendix K process to extend the Appendix K, it's a difficult task to prepare, but it doesn't necessarily take a long time. These waiver amendments require a public comment period, which takes a while. These public comment periods, generally speaking, I think we can get it done probably in a 2-month period of time, but we're on a deadline. And if we don't get that submitted, this is a grave concern for all waiver providers that if those amendments aren't submitted by November 11th, that those rates will go back to what they were in 2019. I've included a timeline in here just so you all have it in front of you about exactly what has happened and what needs to happen. But we had some recommendations. And the recommendations are to, 1, implement the recommendations from the 2020 and 2021 task forces. Encourage the Cabinet for Health and Family Services just to submit those waiver amendments before 11/11/23 and to make sure that that House Bill 1 rate increase is included in those amendments. Include technical language for you all in the upcoming budget, just making very clear that the House Bill 1 the 2022 House Bill 1 rate increase will be made permanent. This is a technical step just to finalize that. The General Assembly did state its intent to make that permanent within the budget. So this would just be a follow-up to kind of finalize that. To include funding for a 2, 4, 6, 8-year waitlist phase-out proposal in the upcoming budget, and to encourage the Cabinet for Health and Family Services to finalize the rate study. I know I've kind of thrown a lot at you, and this is not an exhaustive analysis, of our waivers. These are kind of just the biggest issues today. But the legislature conducted 2 task forces, and we still didn't get time through all those to kind of fully examine everything in our waivers because there's a lot to talk about. These waivers are a tiny part of the Medicaid budget, but to the over 30,000 people that are enrolled in the waivers, they literally change their lives and they make the world of a difference. They are the difference between staying in their homes and staying in their communities in institutional care, which isn't always appropriate. So thank you for the time to be able to present, and I'm sure Steve or I would be happy to take any questions.
Questions from the committee? Representative Mosier.
Thank you. Thank you for this presentation. This is a lot of information. And it helps that I just had a meeting about this prior to this. So thank you. And thank you. I want to go back to, and I appreciate all of your recommendations. I am happy to look at the budget with others and see how feasible all of those are. But back to the wait list management. Are there any CMS rules that would preclude doing some sort of an assessment and communication to the members who are on the wait list, and a referral to other services if they're appropriate? I just feel like, there's so many people on the wait list who aren't ever communicated with. They're not really vetted as to whether or not this is appropriate, and it just gives them false hope and it leads to frustration.
And there's probably duplication across wait lists as well.
Right. So is there anything that we can do about looking closely at the wait list?
I don't know specifically what the answer is to that. I think it's a great question. That's a real key part. I think waitlist management have some idea. Ideal world, if it was permissible, you'd have an idea of if it's 1 through 10, what that person is going to cost, and you can actually come in your budget proposal.
Right.
For $12, we can serve 7 people. For $14, we can serve 11 people because they have less support needs. I think they tried to do that, and there was some concerns expressed that Medicaid staff couldn't make that decision on the Michelle P. waiver. That was maybe 4 or 5 years ago, and they were having evaluations, groups of 100, and that had to stop because I think CMS says you can't make that determination until they get a placement. It's probably a better Medicaid question. But some idea who they are, what their needs might be, and I know people who are shocked when they get communication that you're on the wait list. They said, well, when did that happen? Well, they probably went to an event someplace and filled out a form. But I still think that's part of understanding what it looks like, and that's part of the strategic approach to waitlist management, I think, so you know who they are. Is it possible at some point to have kind of a super wait list that applies people to the right waiver when they become available, and what are their needs? The SEL has an emergency and urgent. Other waivers don't, so if you know someone who gets on Michelle P. today, they're going to be at the bottom of that list, and maybe they become an emergency for the SEL at some point. I think it's those are good questions. I think it needs to be done. I think obviously what's permissible, and how do we make sure that it meets the needs of the individual on the list more so than, this is important stuff, but that individual needs to have some idea of, when is there hope? When's it going to happen?
Yeah, so I just don't know how, without some sort of screening and, a realistic look at the wait list, how do we fund it?
Right.
I mean, because we're basing all of your numbers
off average
on the wait list.
Yeah, and it's all average.
I mean,
so
if it's not real, then how do we get that answer?
Yeah, and part of the problem is that specifically with these wait lists is that they sort of operate in silos, and there's not a ton of information about the waivers out there anyway to the general population. Obviously for children on the wait list, which is going to heavily be the Michelle P. waiver wait list, there are, EPSDT through schools, therapies and things like that available to those children. For adults, there's not a ton out there because, again, these are non-medical services, support services that we're talking about that don't exist in other realms. And so it is difficult to sort of refer people to other places. There is some emergency funding out there. There's the Heart Supported Living Grant. I mean, there's piecemeal things, small money throughout, but nothing substantial to my knowledge.
Okay. I have a follow-up and then one more quick question. How do individuals get on the wait list in the beginning? I mean, so do the pediatric patients go through their pediatrician, or is there some sort of stipulation that the individual has to have a physician make the recommendation?
So there are criteria for all of the waivers about who would be applicable. One of the issues with the Michelle P. waiver is that there's not an accurate pediatric screening tool. That waiver was really designed for adults, and we have a tremendous amount of children who need services on that waiver that we don't necessarily have a tool that appropriately addresses. But you can just apply to be on the wait list. there, I am sure, are people.
Form.
Yeah.
Called a MAP 10, I think the number, and a physician, an APRN, a PA, a qualified intellectual development disability specialist can sign off, yes, this person, and that moves you forward. It doesn't necessarily move you to the top. Interesting, some families are scared because you really have to meet level of care for an institution. And some families are scared to do that for them because does that mean my child's going to go to an institution? I don't want that. You know, it's really, are they eligible, not will they go? But I think that's part of what.
Yeah. And are there some people on the wait list that probably won't end up qualifying?
Yes.
Yes, there are.
I just think this is a huge opportunity, for some clarification around this for the families and for us. We don't know what to fund.
Right.
And the worst thing would be waiting for services for 10 years only to find out you don't qualify.
Right. No, exactly.
Yeah.
I think that's just ridiculous. I think that if there's a way to really dig down on this, that we need to. And that wasn't my last question. I just want to talk for a minute about just the reallocation of the waiver slots when an individual dies or relinquishes their spot. I mean, that seems like an easy fix. Do we just need to apply for some federal approval to do that? Or again, are there so many convoluted strings attached that...
I believe it just requires an application. So I reached out to several colleagues who are involved in trade associations in other states, and they all were surprised that we don't do that.
Yeah.
So, I mean, I think that it is possible. I think that it just requires application. It probably will require a waiver amendment because those waitlist policies are written into our waivers and then amendment of our regulations. But, certainly those things seem possible.
Okay. I'd love to talk to you about how to do that.
Yeah.
And maybe DMS. All right. Thank you.
I think what's missing from this discussion, and it's not particularly from the Michelle P. waivers or any other waiver we have, is the cost associated with doing nothing.
Correct.
And I wish there was some way we could identify that, and that in itself could provide a substantial portion of this funding if we could identify those costs. So it's a shifting of resources, and we need to do that in some form.
And I kind of figured that question was coming, sir. Mm-hmm. State psychiatric hospitals, there's some folks there with intellectual development disabilities get admitted to those because that's where they need to be. They may not meet that criteria, involuntary commitment. My understanding is sometimes there's a 202B process as an involuntary commitment for people with intellectual development disabilities. Those requests have increased, so that's a possibility. I think there's other pieces of the social system that gets interacted when people struggle, when families struggle. You may see it, I don't think law enforcement, maybe increased hospitalizations, increased visits to ERs for some people perhaps. Could it be that mom or dad has to quit work because they have a 22-year-old son or daughter, or they have to cut back on their hours? That's another cost offset that is a real thing that people have to encounter when their kid is no longer in school. I've known families that almost figure out how to make summer work for some people when their kids are in school and then they're not in school, so they take 2 weeks here, a week here, get someone else to fill in. That's a cost to those families. So I think and I've heard you say many points, what's the cost of inactivity essentially? And I think those are places where those costs will show up. We'll see those costs. We'll see those costs perhaps accessing pediatric services more, hopefully, or even other primary care. Behavioral health services for some people may increase when you're trying to figure that out. It's a unique population that needs supports. We know they're going to need support for a very long time. I'm a proponent of a waiver for people who's really mentally ill, but I think it's a similar situation for those folks. There is a work group looking at children's waivers, so I think it's an opportunity to stop and wonder, figure out what's the next step. But I think there are some places. Can we cover the full cost? I should say yes. I don't know if that's a realistic answer, but we can help offset some of those costs and provide better services to the individual as well.
I would agree. And Secretary Freelander, I would probably ask for your impression of this presentation today, but I'm not going to do it today. I'm going to give you time to think about it. I can see you're eager to do that, but I'd appreciate it if you give some thought to it, and maybe at a future meeting we can have some additional dialogue on this. But appreciate your presentation today. It's always very insightful and a big part of what we do. So thank you very much. There are no further questions or comments. Our next meeting of this task force will be on Tuesday, September 26th at 3 p.m. in this annex, and Co-Chair Meade will be chairing that meeting. So if there's no further business, we will stand adjourned. Thanks, everyone, for your participation. Appreciate it.